everyone. Welcome. It's a Wednesday evening, and I'm glad that we are back with some more success stories, with some more topics. As you know, yesterday we actually talked about recurrent miscarriages. Tonight we will continue this particular topic. This topic definitely brings lots and lots of questions, and we have a special guest with us. Dr. Ksenia Khazhylenko is with us. So, hello, Dr. Ksenia. How are you feeling? And thank you
Hello,
for
I feel good.
joining us.
Yeah, hello, everybody.
Hello, and how are you feeling? All is good, I hope.
Yeah, thank you. All is good. Thank you, Carolina, for inviting me and for organizing in my first experience here in your platform. And I will be glad to answer a question on our guests today.
Excellent. That's why we are here for sure. So, as always, you know that we will start with Dr. Ksenia's presentation. She will provide success cases, of course, based on recurrent miscarriages, patients that went through recurrent miscarriages. And afterwards, as always, there will be time for your questions. So, don't forget to type those in the chat section so that Dr. Ksenia can help you out with them. And as you know, we are here not every single day, but we are here very, very often just to support you, to give you this opportunity to ask your questions on various topics. And this autumn, we are focusing on success stories. And of course, the more success stories we've got here, the more happy we are, because that means that whatever any doctor is doing, that works, even though there are sometimes some obstacles. There are not easy cases for sure. But of course, we always need to look for positives, and it can happen. It can happen to you, but there are always some options that doctors can find and diagnose, and then fix this as well. And of course, this success story that Dr. Ksenia will present is about this. Okay, so stay tuned, have a look at this, and of course, remember to ask your questions. This is your time, and remember, this is free of charge. It's anonymous, so you can just feel free and go ahead and do it, and use this time to get some advice, perhaps as well. Okay, and this is it from me at this point, Dr. Ksenia. Let's begin with your presentation then. Okay.
So let's start. Thank you. Thank you one more. And I'm ready to start my presentation. Sorry, this is the second slide. And I would like to start for the first one. And I would like to present to you two cases of my patient. And I would like to show you on these cases that recurrent pregnancy losses, it's very complicated condition, very multifactorial, and circumflexes of this condition can be very complicated, and our conclusions can be sometimes very difficult. So I also would like to show you that not all, that sometimes success of recurrent pregnancy losses patient, not just a medical success, sometimes it's part of the miracle. And I want to start from this very, very famous Shakespeare citate. Let's move on. And this is my first slide, first story. It's Victoria. It's my young patient. She's 28 years old, and her husband twice older. And then she came to me with a history of 5 so-called biochemical pregnancy, biochemical or preclinical pregnancy. It's pregnancies when she had just a positive test on pregnancy, and then when she provided blood test of hormone, ACG hormone, she had just a little bit higher level of ACG, and then it started to drop down, and she started to bleed, unfortunately. And she had 5 this experience, and on first consultation she was very, very tired. I can even say that she was exhausted, and she was disappointed. She was almost depressed, and of course despaired. And she came to ask me about IVF program and about what how can I explain her negative experience. So, firstly, I studied her test results, and the good news that she had absolutely normal karyotyping, body mass index, uterine anatomy. She had normal ovarian reserve, and her husband, despite on age, had absolutely normal semen parameters, and also she had normal thyroid function and endometrium, and no signs of endometritis. So it was the good news. But she also had you can see she had high risk of thrombotic events because she has high level of antiphospholipid antibodies, and it was twice. And she was, unfortunately, despite of this history, she was smoker, and she smoked 10 cigarettes a day during a very, very long time. And also, additionally, she was homozygous on PAI mutation, and also it's very important that in your family history, your mother died quite early from thrombosis. So, of course, she had very high risk of thrombotic events during pregnancy, and her conclusions was recurrent pregnancy losses and, of course, antiphospholipid syndrome. Antiphospholipid syndrome, it's the problem for the pregnancy, and of course, this is a situation with high risks of thrombotic events during pregnancy. But mostly these thrombotic events can happen a bit later in the second and third trimester, and because for thrombotic events in placenta and umbilical cord, we need to have these blood vessels. And in very early pregnancy, I hesitate that it was possible. And also there are some publications about antiphospholipid antibodies in patients in IVF programs. And there are some data that this patient sometimes can have even increased possibility to become pregnant in IVF program, but unfortunately with worse result during second and third trimester. So I had to explain to Victoria all my ideas, and I had explained that maybe the reason for her early miscarriage was antiphospholipid syndrome, but in real life, mostly of very early pregnancy losses are because of chromosomal pathology, of course. So before making the decision, I explained her, and she have to choose between natural conception and IVF program with genetic testing. But anyway, despite on your choice, she had been treated by antithrombotic therapy, by low molecular weight heparin and aspirin, despite on natural conception or IVF. So Victoria have chosen IVF program, and we have started from ovarian stimulation, and we took during stimulation 20 eggs. It was good for your age, and almost all eggs were fertilized, and we took 8 blastocysts, and it was good result for your age and for your number of eggs. But as you can see, just one embryo was euploid on result of genetic testing, and it was absolutely abnormal for this young age. So, first conclusion that the reason of early losses can be in chromosomal pathology, despite on her normal karyotype. So, Good news that she had normal euploid embryo, and we could plan embryo transfer. And embryo transfer was provided in a natural prepared cycle. And of course, we have started low molecular weight heparin and aspirin from time of transfer. And good news, she was pregnant, and she was appointed to ultrasound examination firstly after 2 weeks after positive result. And this is not the end of this story. And this is your first ultrasound, and it was wow news, because on ultrasound you can see it was twin despite one single embryo transfer. Yes, sometimes approximately 2% of single embryo transfer we can have twins because of splitting of embryo in the very early stage after implantation. But majority of these twins are monozygotes, so they are in origin from one embryos. And usually this type of twins on first ultrasound we can see just one amniotic sac with two embryos, but there is on the picture you can see two amniotic sac with two absolutely different embryos. So what can be the reason? What can be the problem? Is it what happens? So in this case, firstly, we can think about not about splitting this embryo, but we can think about natural conception before embryo transfer. So it was natural cycle, and traditionally before transfer in natural cycle, we strongly recommend to patient to use contraception. But unfortunately, not always patients use our recommendation. And anyway, when we see twins, dichorionic diamniotic twins, as on this picture, on this slide, firstly, we can say about this situation with natural conception plus pregnancy after transfer. But it's not a good news, because this was the program with genetic testing, and we know that one embryo was really healthy with female normal karyotype, but if it was natural conception, so we don't know nothing about second embryo, and it was can be really the problem. So on this first ultrasound, we didn't know what happens. Let's look what will be next. So it was twins, and of course, as I have already mentioned, I started antithrombotic prophylaxis from embryo transfer, and this antithrombotic therapy was very, very complicated during the pregnancy, because she bleeds all the time. She bleeded from early pregnancy. It was not spotting. It was sometimes severe bleeding. From one side, we know that during pregnancy after IVF, especially in case of twins, our patient can bleed, can have spotting in early pregnancy, and sometimes it's normal, but it was really strong bleeding, and we thought a lot. We provided a lot of tests, but we decided firstly cancel aspirin. It was canceled in the 80th week of pregnancy, and later we have cancelled also low molecular weight heparin. It was very risky for this situation, because we know that patients with antiphospholipid syndrome can help not just miscarriages and not just intrauterine deaths, but they can have also later obstetric complication. And in this situation, we decided to cancel antithrombotic therapy. It was our with Victoria decision, because she was really very worried, and I can understand her. and she decided don't use these shots despite all the risk for the future pregnancy. And this pregnancy progressed till 30 weeks of pregnancy. It was normal, but starting from 30 weeks, intrauterine growth restriction started from fetus. And during 1 month, it was monitoring of condition of both fetuses. And after 1 month, condition, one of them become worse, and was disturbance of blood flow, and it was decided to induce delivery. So her delivery was by cesarean section regarding the situation, and it was 2 girls. And 2 girls, as you can see, the discordance between these twins was almost 50, not almost, it was 50%. But fortunately, despite this, both girls were healthy, and now they are 6 years old. They are healthy now, and you can see that they are identical. So the answer on the question, on first question of first ultrasound, what happens? This embryo have split it after embryo transfer, after implantation. It was really very uncommon situation with monochorionic twins with 2 different amniotic sacs. It was really rare. So what is the conclusion from this Victoria's history? The first conclusion that RPL can be caused by different conditions, and despite some very obvious conclusion, we need to continue our testing, our examination, even if we thought that we know all about possibly reason, because we can it can be the mistake, like in the Victoria's situation. The second, that despite first conclusion, early losses mostly happen due to chromosomal pathology. So we need to provide full examination. The next conclusion, that antiphospholipid syndrome, it's really the risk for the pregnancy, and without treatment, a patient often have not just pregnancy losses, but also late obstetrical complication with neonatal risks. So the treatment is very important. The next one is that if we suspect chromosomal pathology as a reason for recurrent miscarriages, we should at least discuss with patient IVF program with genetic testing. It can be very helpful in this situation. We also should strongly recommend contraception, because before transfer in natural cycle. And we should keep in mind that sometimes single embryo transfer can result in twins, even in dichorionic, diamniotic twins, like in Victoria case. And this is a unique photo, because it's a real Victoria photo, Victoria embryo before transfer. And this collage was created by embryology, who provided embryo transfer. And she was impressed by this embryo. This is on the picture. This is not splitting of embryo. This is a process for expanded blastocyst who want implants very much. And our embryologist, she saw in this picture this very similar to the picture from the right side situation. And it was the time when we didn't know result of this pregnancy. We didn't know about twins. We didn't know about what happens with Victoria. Up to me, it's a really unique story and a unique photo. So let's move on. Let's move on for the second case, and this is the patient Anna. She's in her middle reproductive age, and she came to me with 3 pregnancy losses, early, the same, but it was not biochemical, it was clinical pregnancies, but first trimester losses. And in one of 3, this pregnancy was provided genetic testing product of conception, and the result was so-called normal female karyotype. So let's look on the test results. On the results, they are mostly normal. Thyroid function, she didn't have antiphospholipid antibodies. She had normal BMI. Her husband had normal sperm parameters, and in conclusions which she bring to me, uterine anatomy was described as normal. So this is on the left side your previous conclusion, and on the right side the picture with 3D ultrasound which I provided, and this is, you can see, this is typical uterine septum in this photo. And what does it mean? It means that it was the very common mistake, very common for the last year. Maybe it's not now, but 3 years ago, it was typical that uterine assessment was provided on 2D ultrasound, and this is despite on recommendation of American and European Reproductive Society, that the best way to provide uterine cavity assessment by 3D ultrasound, because very high sensitivity and specificity of 3D in diagnostic of uterine abnormalities. So this is the gold standard for uterine assessment. And what do we have? We have also the results, so-called, I mentioned that it's so-called normal female karyotype. So why, what's wrong with this karyotype? The problem is that this is miscarriage. First one, that is miscarriage. The second one, this is very early miscarriage. And in very early miscarriage, when cytogenetic provide testing, he or she should share embryonic and maternal tissues. In a very early pregnancy, it's very difficult because embryonic part in early pregnancy is very, very small, as you can see in the first picture. And after 8 weeks of pregnancy, usually we can very easy share these 2 parts, maternal and embryonic. But in early pregnancy, usually when we get the result with normal female karyotype, in most cases, it means that it's maternal contamination, that we tested maternal tissue, but not embryonic. Of course, in early pregnancy, if we get the result with, for instance, normal male karyotype, it means that it's not maternal contamination, of course. And when we get abnormal karyotype, it also means that it's not maternal tissue. But in this case, before 8 weeks of pregnancy, we can be sure that it's really embryonic or not if we didn't test maternal blood for this type of contamination. And what do we have with Anna? We have, of course, recurrent miscarriage. We have uterine abnormality, septate, so-called septate utera. And also we know we have unknown chromosomal status, 1 of 3 miscarriage, and we don't know nothing about 2. miscarriages. And as in case with Victoria, we can decide the same in this situation, that will be better to provide pre-implantation genetic testing. Maybe yes, maybe no. I don't know. We should to discuss it with patient. But firstly, I should discuss influence of uterine septum in pregnancy. Is it really a matter in all situations? Is it really a problem in 100%? Exactly no, because sometimes we can find uterine septum in patient who during, for instance, during cesarean section, or in patient who had normal delivery, and it means that not always the septum can be the problem. The matter is where is the place for implantation, and you can see on the left picture that in case if implantation occur on the walls of uterus, left or right or back on in front of, it's a good idea at a good place, and in this case the pregnancy can be absolutely normal. But more often with in history with septum, embryo want to implant on the septum, and implantation on septum, it's really risky because it's not normal myometrium, it's not normal endometrium in the septum, and implantation in this place usually ended on miscarriage. So the matter just on place, but even in case of IVF during embryo transfer, we cannot put embryo on those place we want, because usually embryo choose by itself the place for implantation. So what to do? We need together with Anna to choose between metroplasty to remove uterine septum or not, or just wait. Or the second one, we should choose between IVF and natural conception. And she have chosen, sorry, it's a bit early, and she have chosen expectant management and hysteroscopy, and you can see that quite early after hysteroscopy she became pregnant, and her pregnancy was almost well, but just from 16 weeks she had shortening of cervix and so-called cervical insufficiency, but cervical cerclage was successfully used. Cervical insufficiency, it's typical situation for women with uterine abnormality. Despite on surgery or not, they can often have shortening of cervix during pregnancy. So cerclage for Anna was successful, and she gave birth at term with normal, healthy girl, as you can see. And what are my conclusion from this situation? Firstly, that the gold standard for uterine cavity assessment is 3D, of course. And for patients with septum, we should propose and should discuss with them metroplasty, but expectant management also could be option, because as I mentioned, this pregnancy can be absolutely normal. And during pregnancy, despite on surgery, these women have risk of cervical insufficiency. And also my conclusion that the result of genetic testing in early pregnancy sometimes need additional review, as I show in my previous slide. And at the end of my presentation, I would like to just present this modern conception for reproductive medicine and for recurrent miscarriage and for infertility treatment, that patient who came to reproductive clinic should not just become pregnant, not just give birth, but the last result, the main result is take home baby. Yeah, she have to come home with healthy baby. This is really good result and good idea. And I thank you for your attention. And this is my clinic in Kyiv, Ukraine. My clinic provides almost 2,000 IVF cycle per year, and I really proud that is a place of my work. And the last slide is my city, Kyiv. It's my favorite place on the planet. So from Ukraine with love, and this is the finish of my presentation. And I'm ready to ask you questions if they are. Thank you.
Ksenia, thank you so much for providing those details, those two cases. Definitely not easy ones, but of course, as I mentioned, this is amazing that you are still able to get that successful outcome. And of course, right now, as you are very right, it's time for your questions. So as always, if you have any questions, this is your time. Dr. Ksenia is here for you to answer anything that you might have. But also, I always want to remind everyone that if you would like to get in touch with Dr. Ksenia and anyone at the team at the IVMED in Kyiv, then I'm sure they will be more than happy to help you out with any questions that you might have. So yeah, don't hesitate. Go ahead. Okay.
Don't
Wait,
hesitate.
okay. Sometimes we just need some more minutes for all the patients to think about their questions. So let's give it a minute. I don't see any yet, but I'm sure there will be some. So let's wait.
I'm not sure. I don't know where to find this.
I will show you in a second. We just need to wait for the very first question, okay? So if you have any questions, this is your time. Okay, first question. Okay, thank you, Ali, for your first question.
I need my glasses.
Yes, of course. I will read it for you as well. So, what is the most common problem that miscarriage patients face?
Okay. This is a good question. Thank you. And all depends on really on term of pregnancy. As I already mentioned, for early pregnancy, the most cases caused by chromosomal pathology, of course. But if we are talking about late term miscarriage, when we are talking about miscarriage, we mean that the last term of pregnancy for miscarriage is 22. For Ukraine, it's a bit different for different countries, but for Ukraine, it's 22 weeks of pregnancy, also called obstetrician weeks from first day of last menstrual bleeding. And for different countries, it can be even 24 gestational age weeks. So when we are talking about miscarriage, so about first half of the pregnancy, for the early term, it's chromosomal pathology. For the last late terms, it's more about blood clotting problems. But in the middle of these terms, we are usually talking about uterine problems, uterine abnormality, endometrial abnormality, chronic endometritis, and also, as I have mentioned, this is shortening of the cervix, cervical insufficiency, which usually start from 14, 15, 16 weeks of pregnancy. So this is most common reason. And when we are talking about terms more than 22, 24 weeks of pregnancy, it's not miscarriage, it's pregnancy losses. It can be intrauterine death. So for these conditions, they are absolutely different. Different reasons.
Thank you for your very first question, as I mentioned, Ellie. And thank you, Dr. Ksenia, for explaining, of course. As you can see, more questions are coming up. Now, let's have a look. Leah has another one. Age 36, 5 miscarriages in early pregnancy, 5-6 week. Pregnancy made with IUI, all tests that doctors need to see, karyotype, genetic testing, hormones, etc. are made, and there is nothing to prove. Why is this happening? Any advice?
So the same, very early pregnancy, very early term, and it means that often when we are talking about karyotyping, we just it's not full explanation, because mostly chromosomal pathology in embryos happens during conception, during when sperm fertilized the eggs. So in majority cases of chromosomal pathology in embryo, the parents have normal karyotype, and so normal karyotype of parents doesn't mean that you didn't have a problem with chromosome. But the decision in this case, it's not very easy, because age is 36, so chromosomal pathology is more realistic, enough realistic in this situation. And it means that from point of view evidence-based medicine, we should discuss with this patient the same two ways, or IVF program with PGT, or natural conception with possibly trying, or don't do nothing, or to continue provide some testing which don't have enough proofs. It means that there are a lot of so-called, for example, immunological testings, but these testings don't have enough evidence base, and maybe if patient have choose natural conception, maybe sometimes is just one way to try to do something. But sometimes after explanation, patient choose IVF with PGT, and in this case, it can be very helpful, even if the reason of the miscarriage was not in chromosomal pathology, because when we provide genetic testing of embryo, it's we can explain prognosis for this patient, and we can explain previous situation, because we know for any age group of patient, we know how many normal and abnormal embryos do we normally have. And if for result of this patient we have middle number of normal and abnormal embryos typical for this age, it means that the previous miscarriage was not caused by chromosomal pathology, and we need to continue find something else, immunological problems, some additional blood clotting problems, and so on. But if we choose natural conception, we don't know nothing about chromosomal status of embryo. In this case, we need just wait and maybe use progesterone, and that's all.
That can be checked. There are still things that can be checked. I mean, so yeah, I guess we still need to keep on trying and look for the solution. Yeah. Thank you so much indeed, Olia. I do believe it has been helpful. And of course, you can still ask more questions if you wish. Another question, what about chronic endometritis? What advice on that?
What do we do with chronic endometritis? We treat all over the world. We have to treat firstly chronic endometritis at least one time. But what to do? It later it depends on chronic endometritis in patient with RPL. It's absolutely different. Carolina, we discussed with you before this webinar. It's absolutely different from infertility patient group. And when we find out chronic endometritis after miscarriage, we never know really it was the reason, or it was the condition after or because of miscarriage. Because sometimes chronic endometritis go after second, third, and so on miscarriage. So when we have chronic endometritis, it's not just inflammation. It means changes in endometrium, sometimes with micropolyps, sometimes with polyps, sometimes with uterine adhesions. And if after treating or before even treating of endometritis, we see on ultrasound some changes in endometrium, will be better to provide hysteroscopy, of course. If there is no any signs of endometrial pathology on ultrasound, we just need to treat. And then I recommend to provide testing to be sure that we have really treated this endometritis. So provide biopsy of endometrium months or 2 months after the treatment. But sometimes at least 10% of patient after treating chronic endometritis and terminal endometritis, the control results are also positive. And the main question, what to do with this patient. And there is no international society recommendation for this situation for resistant chronic endometritis when control second test are positive. Don't have any recommendation what to do second course of antibiotic. I don't like this idea. Or just wait, or just plan pregnancy, or to do something else, because for the patient with infertility in IVF program, answer on this question is much easier, because in patient with IVF, before transfer of embryo, we can use some medication to off menstrual bleeding. One of the main reasons for recurrence of chronic endometritis, that is utero bleed every month, and this is the possibly reason for recurrence of inflammation of endometrium. So in case when we plan embryo transfer, we can just off by a different medication in the menstrual bleeding on 1 or 2 or 3 months, and then do embryo transfer. And usually this strategy is effective enough for the result. But for natural conception, it's not a decision. We can off menstruation and plan natural conception. It's different. So there is just 2 possibly ways when we didn't treat endometritis after first course, is to provide hysteroscopy and remove all the endometrium. Sometimes it can be the problem, because in some patients after full removing of endometrium, it's good idea for the endometritis, but it's not a good idea, because some of them then have very thin endometrium and adhesions. Or choose second course of antibiotic. This is my answer.
All right, it's definitely not an easy question as well, because it's definitely a complicated
This is
The chronic.
complicated situation.
Exactly.
Yes, it's very not
We could have, I
no
guess, we could have even definitely a webinar on it, and it would be still hard
just
to exactly say
yeah.
that it's, kind of yes or no kind of answer, of course. Thank you so much for bringing this, Roman, of course, as well. Yeah, let's have a look. Yessi has another question. 40-year-old, second time failed to implant via Pixie, have high NK cells. Any advice?
If we are talking about, it's not about recurrent miscarriage, but about patient. I think patient with RIF and recurrent miscarriage is very close patient. But I don't know. This is the question about the program with genetic testing of embryo or not. Because I usually give advice about NK cells just in fertility treatment programs, just for patients with genetically tested embryos. If it's not tested, if we don't know chromosomal status of the embryos, it's not a good idea to do something with NK cells. But if they are genetically tested, we can do something a lot of ways. But I have mentioned that it's no evidence base for this treatment. There are different type of treatment. It depends of not enough information, because NK cells it's 70% of all immune cells in endometrium, but it's not all. Disorders in a patient, we need to do some additional tests to study blood, to study T cells, to study different part of immune answer in endometrium in the blood. But if it's just NK cells, high level, so it means that we can use some advices. I can use infusion of intralipid. It's the most popular for today infusion. It's very effective. It's not. It's cost effective. It's medically effective and with very low possibility side effects. So this is most popular treatment of high NK cell 7 level. But one more that it can be not just NK cells. It can be about different immunological disorders. And the first one, it's genetic status of the embryo.
Okay, thank you so much. Yessi, if there's anything you would like to add, just to clarify, perhaps, go ahead, type this in, of course.
Yeah.
Okay, and I'm sure Dr. Ksenia will be happy to give you more details. But thank you so much. And for now, at least, might be our final question. So if you have any more, this is the final call for those. Okay, go ahead, type those in. And Ali has added one more question. So how useful is checking thrombophilies and antiphospholipid antibodies in cases of RPL?
Thank you for the question. And this is about different situation, because about antiphospholipid antibodies, it's strongly recommended for RPL patient in any term of pregnancy losses, but because there is strong association between antiphospholipid syndrome and recurrent miscarriage. But about thrombophilia, it's a bit different, because there is no enough proof for association between thrombophilia and thrombophilia. When we test the patient on thrombophilia, it's not about real risk for the pregnancy. It's about general risk. So testing for thrombophilia was started, if I write, about 50 years ago for patients whose relatives had thrombotic events. and the thrombophilia risk for those patients means just have they additional high risk of thrombotic events in the future or not. So to do for them some additional tests, some additional observation, or what to do if thrombosis occurs. So for RPL patient, it's a bit different. When we test for example, our situation with Victoria for my first case. She was tested on thrombophilia. I have mentioned the result. It was some of middle risk mutation, but she had so strong other risk antiphospholipid antibodies. It's the first one. The second one, she was smoker. This is additional risk for the thrombosis. She had family risk of thrombotic events for relatives of first degree. It means that without, even if she doesn't have any thrombophilia mutation, she have enough thrombotic risk to make a decision to provide prophylactic. So in this case, thrombophilia testing don't have any additional sense. And if we provide thrombophilia testing in patient when really problem of real reason of RPL was chromosomal pathology, could we take the positive result for thrombophilia? Of course, yes, we can take get the result for example, for high risk thrombophilia, factor 2 or factor 5 laden. Does it mean that the problem was in thrombophilia? No, the problem was in chromosomal pathology. And thrombophilia risk means just that this patient have a bit higher risk of thrombotic events during her life, but it doesn't mean that it was the reason of recurrent miscarriage or any miscarriage. Fortunately, approximately 95% of all patients with mutation don't have any thrombotic events during their life. So, fortunately, 95% of all patients don't need this test. And we often choose the mistake. We often have not correct conclusion what to do with this patient, and often I can see patient in my practice, in my consultation, that patient have 5, 3, 4 miscarriage, and after second she was studied on different test, and it was positive on some thrombophilia mutation, and then during third, fourth, 5 pregnancy, she was unsuccessfully treated, but low molecular weight heparin, and she had also miscarriage because the reason was absolutely different. So up to me, testing for thrombophilia, it's not obligatory. It's not helpful. Testing for the patient. Syndrome, yes, of course.
Okay, thank you for the clarification explaining this.
Sometimes I expect I have the problems with connection, yeah?
Sorry, right now it was a little bit breaking, but of course, right now I can hear you. I believe everyone can hear you. So thank you so much. Okay. You have explained this brilliantly for sure. Thank you so much indeed. And as I mentioned, it looks like that was our final question for tonight. So I would like to thank everyone for your questions, for staying with us. Yes. I'm glad that we were able to invite you, and I'm glad that you were able to join us tonight and present this topic as well. So thank you, Dr. Ksenia. And before we finish, anything else you would like to add? Can you hear me?
Thank you. Thank you for question. Yeah, I can hear. Yeah.
Okay,
But
because the sound is breaking a bit right now.
Yeah,
but it's okay. We are almost done. So of course, I'm glad that we were able to make it without any issues. So of course, don't worry. And as you can see, there are some thank yous coming up your way here. So as I've mentioned, remember it has been recorded.
Oh, very on Ukraine. You can see.
We cannot hear you very well, I'm afraid, right now.
Thank
it's
you for
breaking a bit, but thank you so much.
For your attention.
We need to. Okay.
Thank you.
Thank you so much. And of course, remember, it has been recorded. You will be able to find it on myivfenses.com and also on our YouTube channel. And of course, we will be back next week on Monday. There is another webinar that we will discuss, another success story. So go ahead, sign up, and that way you will have a chance to ask more and more questions. And of course, as always, you are able to ask questions even after the webinar. You can get in touch with Dr. Ksenia, her team at IVMED. They will help you, no doubt here. Thank you so much. Have a lovely evening, everyone, and see you soon. Okay, Dr. Ksenia as well. See you soon. Bye.